Welcome, everybody. We have a really exciting webinar planned for you all today. Thank you so much for those of you joining us live, for taking a time out of your day right now. For those of you watching later, we hope you enjoy this conversation. I'm going to introduce Doctors Joe Tonna and Darryl Abrams will be our moderators for today, but we're really fortunate to have assembled a great team of colleagues, especially related to ECPR. So we'll first talk about the recent study that Jan and his colleagues have just published, and then move on to a couple other colleagues that are leaders in this field. So Joe and Darryl, go ahead. Thank you.
Thank you, Christine.
My video seems to not be allowing me to show me. But I'll just talk without a video. So my name is Joseph Tonna, and I'm an intensivist at the University of Utah. My colleague here is Darryl Abrams, an intensivist at Columbia. And we're very happy to host the panelists today. This is the only opportunity I've had to get together the three PIs of the three ECPR trials that have been published, randomized controlled trials. And so I'd like to introduce everyone today. We have first and foremost Jan Belohlavek, who is the PI of the recently released JAMA trial on ECPR. And he'll be joined by his colleagues today, Daniel Robb and Jana Šmalcová. And we also have Demitris Yannopoulus, who is the PI of the ARREST trial. And we have Roberto Lorusso, who is the PI of the Inception trial. And they will be our panelists today speaking about their trials and putting them all into context. Thank you very much, everyone. So I think without further ado, Jan, if you want to start your presentation.
Good. So dear Joe, dear Darryl, dear everybody, it's my great pleasure and honor to be here with you virtually, at least, and just to have a talk and discussion with such an esteemed faculty on our trial. This is the trial, as you mentioned, published recently, like 3 weeks ago, in JAMA, and it's been a trial performed here in Prague. Czech Republic. Was a single center randomized controlled trial, and we'll talk about this in a detail. For those of you who would like to have a detailed description of our protocol and methodology, this is our protocol paper published back in 2012 before the study has been started. So, and there is in detail describe everything we did step by step. So I refer to this protocol. Now, what was the background of the study before we started back in 2013 was that a refractory out-of-hospital cardiac arrest has a poor outcome. That's obvious. ECPR, even that time, was a very promising intervention. However, the benefit of ECPR in refractory out-of-hospital cardiac arrest was uncertain. And the study actually compared two different treatment strategies. So the first one was an invasive strategy, and it was a bundle of early transport to hospital under mechanical CPR, and we used a Lucas device, followed by ECPR in case that the patient came to the hospital and didn't reach the ROSC during the transport, return of spontaneous circulation, followed by immediate invasive evaluation and a treatment. And this bundle of interventions was compared to a standard strategy, which was standard advanced cardiac life support on scene. We enrolled patients who were adult, 18 to 65, without a hospital cardiac arrest of presumed cardiac cause. They were electronically randomized during ongoing during ongoing chest compressions to either invasive or standard strategy. And this is important that we were in touch with the crew on site of the cardiac arrest, and we discussed inclusion-exclusion criteria during ongoing chest compressions and we randomized at that special moment. So every patient who was randomized during ongoing CPR. The study was conducted from March 2013 and was halted by DSMB in October 2020. And it was started by a pre-specified criteria after 256 patients have been enrolled. For the analysis I'm going to show, we used a strict intention to treat analysis. A couple words how the care has been organized here in Prague. Prague is a mid-sized city. We do have like 1.25 million people living here. The important point is that there is only one emergency service in Prague, which has one dispatch center, and we use a rendezvous system. As you know, in Europe, it's quite obvious and quite often that we have physicians on board in those rapid vehicle crews. And the blue pins are all the crews in Prague with paramedics, and the circled pins are the places where the physician is also on board. And our cardiac center is located just in the middle of the city. The other important method we had was an early short message report and alert to a cardiac center. So this is a screen of a cardiac center coordinator, which is receiving automatic SMS reports whenever the telephone assisted CPR is being started in Prague. And in these SMS, as you can see over here, you can see the age of a patient, and you can see the exact time where the telephone assisted dispatch directed CPR has been initiated. And as you all know, in cardiac arrest, it's very difficult sometimes to estimate the age of the collapse in cardiac arrest, but this is the exact time we had for at least telephone assisted CPR. So how was the flow of the study? During the study period, which was almost 8 years, there was a 4,345 cardiac arrests attended in Prague. And after exclusion of those who did not fulfill inclusion criteria, we had actually 358 patients who were without return of spontaneous circulation, and again 94 from variety of reasons, as you could read. Were excluded, and at the end we randomized 264 patients. After randomizations, 8 were excluded, mainly because we didn't get a informed consent from the relatives. So the randomized number of patients from the all cardiac arrest in the period was 6%, which is nicely in line with other studies showing that a number of patients being suitable for ECPR somewhere between 5 and 10%. And out of those, we had 124 in invasive, 132 in a standard. And as you also know, we did have some crossovers. The crossover was very low for such kind of study. It was 7.6% overall, and it was 9 patients in the invasive and 11 patients in the standard. All this crossed over to the other arm. The baseline characteristics of the study, it's important, and in the standard and invasive, you see mainly males, mainly cardiac arrest occurring on a public place. We did enroll all rhythms, so both shockables and non-shockables. As when we started those 10 years ago with the preparation of the study, the evidence for the PA and asystole was not so strong. So we enrolled all rhythms, and we kept this during the whole study. Despite that, a majority was shockable rhythms. And important point is methodologically that the time from collapse to crew being on site was 8 to 9 minutes. Physician was on board 10 to 11 minutes. We had a very high percentage of bystander CPR, 98, 99%, and just the baseline bystander CPR in Prague overall is over 80%, published in the EUREKA trial a couple of years ago. So the baseline level is very high, and in this study, of course, we had basically all patients with bystander CPR. And importantly, also 80% of patients did have a telephone assisted CPR by the dispatch center, and patients were randomized after 25 minutes from collapse. So 10 minutes for the crew to get on scene, 15 minutes of ACLS on site, and after 25 minutes, patients have been randomized. If you look to procedures we did and what happened with patients actually, so of course in the invasive arm, because there was an intention to get a patient to hospital, almost all were, except for one, were admitted to hospital, contrary to the standard arm where only 66% were admitted to hospital, the rest died on scene. The important for the overall results and for the logistics is that patients in the standard arm were resuscitated for 46 minutes, so very long, prolonged resuscitations. And the time of CPR was defined as a time to death, time to ROSC, or ECLS. And in the invasive arm, it was 58 minutes overall. So we have really picked up very refractory cardiac arrest, which what you can see here in the subgroup definition, that patients resuscitated for more than 45 minutes in both arms was 55 and 73% in respective arms. The other procedural data, like laboratory values, you can see that the patients in the invasive arm, because of longer cardiac arrest, had a poor pH and higher lactates. The cause of cardiac arrest was mainly coronary acute syndromes. And interestingly, we had quite a lot of organ donorships in the invasive arm, as one would expect. So what were the results? As you know, the study was prematurely stopped, despite this fact that we did not reach a statistically significant difference in the primary outcome, despite a clear trend. What you can see that in the invasive strategy, we had a survival of 31.5%, so almost 32% of patients survived half a year, so 180 days with CPC 1 or 2. So this is quite a good if you realize that those patients have been resuscitated on average for 1 hour. In the standard arm, we had a 22% survival, 180 days with CPC 1 and 2. And again, those patients have been resuscitated with a median time of 46 minutes, so very long cardiac arrest. Overall, survival in the study was 27%. This was not different statistically, despite a numerically 9.5 absolute difference. However, we did have a statistically significant difference in the neurological outcome after 30 days. And I'm again referring to other cardiac arrest studies, which have usually 30 days of outcome. This is 30 days neurological outcome, and we picked up truly a very hard endpoint to be sure and to kind of justify such a difficult, complicated, and also resource demanding intervention as we did. So concerning the cardiac recovery, there was no difference, again, despite the fact that numerically there was much more cardiac recovery in the invasive arm. So this is the main result. If you look into the subgroup analysis, and the original picture in figure in JAMA is a little reduced based on the editor's requirements, but this is the whole subgroup analysis we have performed. And there's just two parameters I want to stress. If you look to shockable rhythms and invasive arm, so this is patients with initial VF being transported to hospital, being put on ECMO, being treated invasively, and look at the survival. It's almost 50%, so 48.6% for shockable rhythms, first important point. And the second one is the subgroup of patients being resuscitated more than 45 minutes, who clearly benefited from the invasive strategy, which is this one. In all other subgroups, there was no significant difference, despite the fact that you see the trend of all the subgroups benefit in the invasive arm. Another important figure, which is in the supplementary files, which I recommend to you, is this one. And this is the subgroup analysis of time of CPR, which we interpret following way. So this is patients who survived favorably with CPC 1 and 2, less than 30 minutes of CPR, 30 to 45 and over 45. In these first two groups, there is no difference statistically. However, in this group over here, so very prolonged CPRs, refractory cardiac arrest, you see a clear both numerical and statistical difference in between the standard and invasive arm. And of note, it's necessary to say that within those 6 patients in the standard arm here, actually 4 of them were those crossed over from standard to invasive, so they were treated invasively here, but analyzed by intention to treat in this group. So if we look at them as treated, it would be 2 versus 24, so even more statistically significant. And this is one of the important messages. We have a Demitris with us, so it's obvious we compare those two studies. So Prague study and the Minneapolis arrest trial. So concerning number of patients, we had 256 and versus 30, so almost 3 times more, or 2.5 times more. 124 patients treated invasively versus 15. We had a very similar age, very similar percentage of males. We had a very high bystander CPR in both studies. As I said before, we enrolled all rhythms. RS trial enrolled only shockable rhythms. We randomized patient on the scene versus RS randomized patient on admission in the ER. So, and this is very important for our later discussion. So this is completely different studies. We compared different approaches, treatment strategies versus arrest, which compared ECMO or non-ECMO in very refractory cardiac arrest patients who were transported to hospital. We had a time to randomization 25 versus 49 minutes. Transport time was 26 versus 19 minutes. We had a very similar time to ROSC or ECMO, almost an hour in both studies. And general survival in the invasive arm was 32% in our study, 43. But if we look at the ventricular fibrillation subgroup, we had a very similar survivor. So more than 40%, 49 in our study and 43 in the Demitris study. So let me conclude this short introduction that based on this study, we think that not just ECLS or ECPR is important, but a comprehensive approach, including ECLS, may have an impact on the logistics for out-of-hospital cardiac arrest. So at the moment we have a technology, we have first randomized data, and I think we still need to better define proper patients and optimize logistics and possibly replicate in a multi-center study. And the question now, and this is open for a discussion, and I'm looking for discussion, is how to interpret our study. So the main interpretation based on intention to treat analysis is that it was a negative study, but I think the study had a very many positive findings actually. So I don't consider the study to be negative. First, we had a very high percentage of bystander CPR and dispatch CPR. So this is important, and this is probably the reason why patients survived such a long cardiac arrest. Second, during the all study period, we actually increased survival in the standard arm twice than we expected based on the historical and also the data in literature. So we, when we counted the power analysis for study, we expected in the standard arm to survive 10% of patients, but we did have 22% of survival. So we had a 2 times higher survival than expected. We had an excellent overall survival in very refractory cardiac arrest, so 27% CPC1 and 2 in 180 days. And there was a pure benefit in subgroups. So first in crossovers, as I said, below 8% overall crossover. So we can compare to Eolia, which was more than 30%, culprit shock at 13%. We had 45% CPC1 and 2 in 180 days. So we really picked up appropriate patients for crossover, and they survived well. We patients who were resuscitated for more than 45 minutes benefited from the study. We had almost 50% survival in shockable rhythms, and we had, if we pool all the patients just with ECPR, very long cardiac arrest, 61 to 62 minutes. So those in the standard and in the invasive, we had a 22% survival in the CPC 1 and 2 in those patients. So that's briefly our study, and I'm glad to answer, if I can, any question you might have. Thank you.
Well, great. Jan, thank you so much for the overview of your trial. And first off, congratulations to you and your group for really a massive endeavor. And as you say, a successful trial, even if by traditional methods, considered negative. I think there are a lot of things to take away from this. I want to encourage all the audience to please submit any questions to the Q&A, and we'll field those in turn. It looks like we already have one question. So perhaps we'll start there and then go around with the panel. So one question for Jan: how many patients in the standard versus the invasive group had ROSC, ECPR, or death greater than 45 minutes?
Yeah, there was a 27% of ROSC patients in the invasive arm, and I think little 56 or 60% in the standard arm. I can look exactly. Yes, sustained ROSC on admission was 44% in the standard and 27% in the invasive.
Okay. And here's the next question. How do you explain the high survival you observed in the standard group? And do you attribute that to the high rate of bystander CPR? Is it the kind of the existing infrastructure for cardiac arrest in Prague?
Yeah, yes, this is exactly the point. And this is actually the reason why the study is not positive, because we had such a good survival in the standard arm. I think it's based on a perfectly working pre-hospital system, one dispatch center, well organized, very high percentage of bystander CPR, very strict rules at the dispatch center for telephone assisted CPR, short arrival times, and well organized system in the handover of the patients.
Yeah, I would imagine that certainly makes it harder to distinguish the difference between the two groups. And I just want to emphasize, I'm really excited to have this whole panel here, experts across the field who have all been involved in very high quality ECPR trials. So I encourage the audience to please ask questions, not only to Jan, but we have Demitris here, we have Roberto. So maybe actually throw it to Joe. I think he had a couple questions off the bat to Jan and the panel.
Thanks, Darryl. Yeah, on my very preliminary view of the data, qualitatively, the arrest and the Prague trials seem to have similar results. And yet I think one of the important differences was the arrest trial, as I understand it, was stopped at 30 patients by the DSMB, and the Prague trial was stopped after 250 patients. And I wonder if one of the reasons why the primary outcome for the Prague trial was not met relates to the inclusion of different arrest rhythms and also the higher survival in the standard arm, which led to a smaller relative difference compared to the invasive arm. And Jan or Demitris, if either of you want to speak to kind of comparing those two trials and the results for the audience.
I may start, and I'm glad to hear Demitris on his comments. I think the trials have actually, in terms of results, they're very similar, and they basically show the same. They show that in properly picked up patients, you can get a very good survival if you treat them invasively, mainly in the shockable rhythms. And our trial also has shown that in very selected PA patients, there is also some role for ECPR. So I think those two trials are very in line, and basically the results are the same. What do you think, Demitris?
Yes, hi everybody. I couldn't agree more. I think the fundamental difference between our trials were twofold. One is that Jan tried to assess the system and how it merges together with an available high specialized ECMO center. I try to answer the question, does the intervention itself makes a difference? So I think that my trial was initially more a does this pill work or not in this specific situation? Jan's was does this pill, does this intervention work within the process? And I think that is a fundamental difference between the two trials. I asked the question, if somebody arrives to you after prolonged resuscitation with no pulses, I don't think there is any debate about this anymore. Both Jan's results and our results, and anyone who has done resuscitation for an hour, if a patient doesn't have pulses in an hour, the chance for survival is almost zero. Jan's survival, 27%, is most of the people that pick up ROSC on the way to prolonged resuscitation. Very different kind of, so don't think that my control group was like 6% discharge and 0 at 3 months. That is because no one survives an hour of resuscitation neurologically intact, once in a blue moon, without any support. But the 27%, whatever the 21% neurological intact survival in the Jan's trial, the Prague trial, was people that picked up ROSC after randomization within 15, 20, 25 minutes. Those are the people that we are comparing. So just to summarize this, I think Jan's trial and this trial, RS trial, and hopefully any other future trial, shows that when a certain time point has passed, which is, I think it's above 40 minutes, there is no other alternative. If you have ECMO, it's the only chance you have for these patients. But Jan's trial also opened the question is, when is it a good timing to implement early ECMO? How do you manage your system to access that population? And I think that is really the big question now. Any one of us, just I'll close there, you know there is no equipoise. If somebody arrives to me at 50 minutes of CPR and they don't have ROSC, if I make a decision to not put them on ECMO, they are dead. Like at this point, the moment you stop CPR, they are pronounced dead. And I want to remind everybody that the average duration of CPR in the United States for people with VF is 29 minutes. And yes, some EMS goes to 40, but that's it. If they don't get pulses there, they're pronounced dead. So that, I think, summarizes our two trials.
So in that context, and also just given the higher rate of control survival in Jan's system, and the expenses that must be put into an ECPR program and building that up, does anyone think that would the funding better be placed building up a system like Jan's to react better to basically improve our standard CPR in the type of system that he described, where there's it's coordinated EMS, the bystander rate, encouraging that to some degree. Is it better placed there than the small percentage of patients who we think are going to benefit, with that long CPR time?
I just want to ask maybe my colleagues from my department, Jana and Dan, if they want to add on this. Dan, maybe.
I'm sorry, I just read a question and answers. So okay. Could you please repeat me the question?
Yeah, okay, I'll answer. Yes, that's the point, Darryl. I think this is the point. And this is one of my conclusions from the trial, is that ECPR is a wonderful method. I'm quite sure about that. And the people tend to discuss how to cannulate and who should cannulate, how long to cannulate and where to cannulate. And this is not important. This is just one piece of the chain of survival. And if you want a patient to survive, everything must work perfectly well. So if you are the best cannulator in the world and your patient has a no-flow period of 10 minutes, you have no chance. So you will make a donors, of course. So you need to improve the system. You have to organize your system. You have to make a primary prevention of the things. You have to teach layperson how to perform bystander CPR. You have to insist on dispatch centers to push bystanders to help people to compress the chest. And then you, of course, need to organize the EMS. Usually when the EMS is on site, everything works perfectly well. And we also know that in the post-ROSC trials, there is not too much to think about. There is not too much to improve, maybe some details. But the important thing is how to deal with patients who don't get a ROSC. So, and when to start the intervention. And this is something which I think we partially answered in our trial.
Yeah, I think you and me both for sure. Go ahead.
If I may.
I was going to throw it to you, Roberto, actually. I was curious what in response to that, and also if you can comment a bit on your trial design and how that may further inform the results.
What Jan has just said, I think is one of the most important aspects that we have also to consider. I mean, being in the Netherlands, I think that any comparison with a bike is well done. It's like having a good chain or a bad chain. I mean, with a good chain, you can go everywhere. With a bad chain, you stay still. The problem is here, we are discussing about a very, as Jan said, very complicated and multifactorial process for a success. So first of all, I would like myself to ask Demitris, why did you arrange somehow a different pathway for your two groups? Because if I understood well from your experience, the patient with ECPR went immediately to the cath lab, while the patient undergoing standard CPR remained in the emergency, let's say, department or room. For instance, this, in my point of view, it's not a really trivial aspect. It's very important because you have patients, of course, in the standard CPR, and they have even not access to immediate, for instance, revascularization in case of need, for instance. So my question to Jan and Demitris, because we found also this as a difficult point in the study design. So do you think that, for instance, in this chain, in this very important chain where each pieces must really be included in the right puzzle, is any bad step? And for instance, where the patient should go immediately to the cath lab, like in Jan's study, or in a different department, like in Demitris, as far as I understood. Is this for you, does this make any difference, first of all? And also mechanical CPR. I think that also in Jan's study, Jan mentioned that there was an improvement along the study regarding ECPR. And I saw in Jan's study that mechanical CPR was not a constant for all patients, and patients were submitted to standard CPR, not with mechanical devices. So also, does this make any difference? And this is just talking about the arrival of the patient at the hospital, and then you have the treatment.
Would you start, Demitris, or should I? Maybe concerning the invasive strategy, I would ask Dan to comment, because Dan is my colleague who is performing the subgroup analysis and post hoc analysis. We're going to publish soon, hopefully, on the invasive strategies and on what we did with the patients, actually.
Yes, thank you. Thank you. I would like to say a few words. I must agree with Demitris that our study is very different compared to our trial. I think the major difference is that we really randomize patients pre-hospitally in the field, because we try to answer a critical question, whether the intra-arrest transport plus ECPR improve survival. And Demitris proved that ECPR is the ultimate rescue option. If you have patient directly admitted to the cardiac arrest center, then there is very low chance that the patient will survive with standard ACLS. And I think that intra-arrest transport today without potential ECMO implantation is of no benefit, and potential is harmful for the patient. Because in 2020, Brian Grunow showed nicely in his JAMA paper that patients who are transported to the cardiac arrest center have had worse survival compared to patients who underwent on-scene ongoing ACLS. So I think that our study answered that if you performed rapid intra-arrest transport in a very well established system, you still can improve prognosis of patients. And in my opinion, in future trials, we should assess ECPR together with intra-RS transport, because to compare ECPR after intra-RS transport, we still, I think, in some cases are lowering chances to establish pre-hospital ROSC because of the intra-RS transport. Yeah. So, in my opinion, the very important thing is in the future trials, but also to compare these trials is to understand the difference, because 1/3 of patients still achieve pre-hospital ROSC in the field or during the transport in our trial, which is very different compared to the RS trial. Or probably even it will be very different to the results of the trial from the Netherlands, which will be published in the future.
Thank you, Dan. One of the questions we have from the attendees is from Jim Bakakis, and he's wondering about when the patients were cooled prior to ECMO, on ECMO, and how the timing of the cooling and rewarming went.
Yeah, it's a nice question. Thanks for that. Of course, we are hypothermia believers, despite the fact that we were part of the TTM2 trial, which actually killed the hypothermia post-ROSC, or I should say the late hypothermia post-ROSC. So what we did initially, we did have a rhino chill, which is a device. Maybe you know the device. You put Pringles into the nose, and you cool the brain by the perfluorocarbon. But we had to stop, unfortunately, cooling patients during the transport and pre-hospital because the company actually bankrupted. So we cooled pre-hospitally only about 13% of patients, and then we cooled patients immediately after admission. If ECMO was implanted, they were cooled by ECMO. If not, we cooled patients to 33 degrees by either invasive CoolGuard device or with external cooling. After the TTM1 trial has been published in, I guess, 2013 or something, we amended our protocol, and in early awakers and in those patients who had obvious complications from hypothermia, like bleeding or severe hemodynamic instability, we cooled them only to 36. So basically, we cooled them as fast as possible in both arms.
Thank you. Dr. Paradis has a question here. He's saying survival greater than 20% after initial failure of therapy is so extraordinarily high that it makes me wonder if there was some selection filter that we're missing. He's wondering if the panelists have any thoughts on that.
Yeah, probably Dr. Parad was our reviewer, because it was a question of the reviewers, how we selected, what kind of bias we had. Basically, I can tell you very openly that I got a call, or one of my colleagues got a call. We have a patient who is somewhere around 60s, been resuscitated for 25 minutes. We are still in VF, or we are still in asystole, we are still in PEA. Would you like to randomize the patient? Then we ask for the inclusion criteria and eventually randomize the patient. So this is the only bias we had. So we didn't have any chance to select the patients, and we randomized electronically. So I just had to push the button on my phone or on a computer, and we got a standard or invasive, nothing else. So and of course, we selected patients. It's 6% of all cardiac arrests. We had to select because we did have inclusion criteria. We wanted witnessed cardiac arrest. We wanted patients where we presume cardiac cause. We of course preferred patients with VF, but as you have seen, 40% of our patients were in PA and in systole. So that's how it was.
Yeah, if I can say a few words, I definitely agree. It's combination of high rates of bystander CPR, high rate of telephone-assisted CPR, and of course, really experienced cardiac arrest centers.
I did want to revisit one of Roberto's questions directed towards Demitris about the different pathways upon arrival to his center in the trial. Maybe give Demitris an opportunity to field that one.
Yeah, sure. I don't think that we had different pathways. I just the path was kind of the same. The only requirement was in order to prove, well, let me just rephrase to understand what the rationale of this was. Cath lab with ongoing CPR trying to do multi-vessel disease is extremely difficult. And even in the best interventional hands, and I, believe that I've done this for about 3 years where I took people with just ongoing CPR, we didn't have ECMO. It can be very challenging. It's difficult to see. It's actually probably at 55 minutes of ischemic time, the heart does not come back easily. Even if you fix one vessel, usually, as you know, and as we've published, and as Jan probably will agree, people with refractory VF have a lot of disease. And as such, what I realized was that in order to give anybody a chance to have a decent angioplasty and try to see what's going on and not be at the extreme skill level of an operator dependent, you needed to have either pulses, so these people have semi-stable, even shocky, return of spontaneous circulation to enter the cath lab, not with a bouncing patient, or they go to the cath lab where the first they go on ECMO in order to stabilize the circulation, provide the hemodynamic stability control that will allow you to deal with a coronary disease. It's very similar to in a situation for cardiac surgery where, yes, somebody will be in shock, but if they're bouncing off with CPR, they will not do cardiac surgery. Now, it's a little different because it's theoretically easier to do an angioplasty somebody who's bouncing CPR, but it's not optimal. And I'm one of the, I don't know how, I've done a lot of those. And so I find them, although are theoretically doable, are suboptimal. So I guess what the arrest trials found out was that if you don't get pulses with regular means, and that was one of the reasons that we didn't have crossovers, is do you need ECMO to have any chance to survive? And without ECMO, you can even identify the cause, right? Or treat the cause. And so I think that the path was the same. The only requirement for a control patient to go into the cath lab was to get pulses, which is the minimum standard for any cath lab in the world to go and get an angiogram.
Thank you, Dimitri. I want to reach back out to our attendees. Stefano Mercurio had his hand up. Mr. Mercurio, do you have a question for the panelists? We've unmuted you.
If you can't speak up, and then you could certainly type in our question and we can ask it that way.
Otherwise, while we're doing that, there's another question that's appeared for Doctors Belohlavek and Yannopoulus. In terms of patient selection and following from Dr. Belohlavek's comment, what were your thoughts on predictive prognostic enrichment in ECMO trials?
I would ask Vasilios to explain to me what that means. I'm not sure what that means.
We'll see if they.
I don't want to answer something.
I would imagine, one possibility as the next question or one of the questions in the chat kind of alludes to in terms of the rhythm, one way to potentially I suppose prognostically, maybe predictively enrich would be focusing on VFIB and scrapping PA asystole as a target population. What are your guys' thoughts on that? As given what would probably have been significantly positive findings in Jan's trial and was certainly positive in Demitris. Is that something that you think we should isolate to?
So I can answer this. I think I've always been a proponent of VF for two main reasons. One is whenever you have a very highly labor and financially burdensome intervention, you have to think about resources and available. So when you start with the intervention with the survival is very low, as a whole population, you end up with a lot of patients that you will have to treat with ECMO, PEA meaning. The PEA survival, at least in the Twin Cities, and I'm not going to talk about Jans because I don't know, in most of the United States and probably in Europe, it's single digits overall. So imagine how many refractory patients in PEA you will get that they have very bad prognosis. Now, it doesn't mean that ECMO doesn't work for PEA, because we have multiple people with PEs here that are young and are resting the ED and they do very well with ECMO, but it's a different question. So if I were to cannulate refractory PA, there would be no beds in the whole vicinity of Midwest because there are so many, and they're going to stay in the whole, 2-3 weeks in the ICU, that there is no capacity for this. So then the next question for me was, why do you use VF? Because there is a reversible cause in many people that I can fix, and they are few enough that I can actually have the resources shifted towards them with a good, meaningful survival rate of 45% or 35%. 1 in 3 will survive rather than 1 in 10. And I think that is just a simple justification. And if you combine Jan's data with our data, VF is undisputably the rhythm that sees the biggest benefit. There is no question. Jan survives 45%, mine is 43%. I mean, you put them together, the p-value is astronomical. There is not even a debate about it. So I would say that VF is a good way to start because you're basically going to allow a system to see success and build upon it. Now, where this is going to end up in the future, I'm going to have minuscule ECMOs that can be placed in a minute by magical wand movement, that'll be a different story. But today, given the resources and ICU capacity, I think in the United States, VF is the only way to go.
Jan, do you think do you have any regrets about the population? Do you wish you had
I must have, sure. I think what Demitris said is a little misleading, and I'll explain why I think this. If you take a context, and we have a Roberto here, so you maybe remember on one of the first cardiac arrest trials from Maastricht many years ago, showing that the overall survival of out of hospital cardiac arrest is 5%. So the question arises, if you have a diagnosis which has potential survival with a very demanding resources 5%, should you perform this intervention? So this is the context we are in. Now we developed for the next 10, maybe 20 years with a lot of interventions, a lot of methods we do for cardiac arrest. And we, as you have seen, we have a 45 to almost 50% survival in VF. If I look at our subgroup analysis in non-shockable rhythms, we did have 5 survivors in the study in the non-shockables. 4 of them survived in the invasive arm, 2 of them were on ECMO, 2 of them were treated conservatively, and 1 in the standard arm. So if you look at these survivors, we have 8% survival of PEA in patients with ECMO. So I'm not sure, and this is not about, this is a research debate and ethical debate. So should you perform the intervention with an expected survival of 8%? I think yes, but in a very selected subgroup of patients. So in PEA, and a very typical patient with a refractory PEA is a young woman with a pulmonary embolism, and with a possibility of pre-hospital thrombolysis. And this is patients we accept for ECPR. But I agree with Demitris that you cannot do it routinely, you cannot do it for all. You have to select perfectly well and be prepared.
So perhaps Roberto could maybe comment, if he has any comments on that, but also give us a little insight into the trial that he recently finished enrolling, and I think is already submitted but not yet published. Just perhaps even just on the design and how it differs from Demitris and Jan's trials, and what we might gain from that in comparison.
Yeah, thanks, Darryl. Well, we have the study design is basically quite similar to the Jan's one, and well, we have a shockable rhythm. That this was our inclusion criteria. And again, the randomization was, of course, outside the hospital. So the primary outcome was always as well a favorable neurological outcome with CPC at 1, 2, or 30 days. And we have enrolled, and it's a multi-center study. This is also very important. We end up with 134 patients included in the study. So I think that what we can say from our experience is, first of all, that the time to ECPR is not so so easy to reach within the, you know, the comfortable boundaries. So of course you start hoping to have many patients in a very short time. But for instance, what is different, at least in our experience with regards to Yannis, in Yannis' experience, I saw a lot of cardiac arrest in public places. I mean, almost 40%, something like that. So this is, in my point of view, very important, because this means usually that the bystander CPR was started almost right away. I am a lot of doubts regarding the in-house cardiac arrest situation. I also, and Jan pointed out a very important aspect. So the patient selection. I think that looking at what we see in patients with cardiac arrest in-house, this is a completely different patient population from the out of house or in public places. So that is also something very important, because the no-flow period, I mean, you rely on what the people made the call, but usually it's not really, can you be sure about the 3, 4, 5 minutes? And this, I think, is one of the major issues regarding neurological outcome, because after all, you can do a very perfect CPR on the way to the hospital and then do whatever you want. But if you have no flow longer than that period, I think this is really no chances to survive as far as at least the neurological performance. So I think, again, in these studies, and we had the same difficulties in a multi-center study in such a difficult setting. I think that at the end, looking at the patient selection, the patient you enroll in the study, there is always such a big heterogeneity. Then I'm not sure. I mean, that's the reason why after our publication, and I think taking Demitris and Jan's studies and putting these at least three studies on the table and looking carefully at each detail, because I think we will be able to achieve even better survival rate if we will be able to finalize the very careful patient selection.
I completely agree, but so why not in next trials just to limit the patients for a public place, cardiac arrest? That's exactly what Demitris said. You have to pick up the most
I would totally, I would fully agree, unless you can really, you can have one cardiac arrest in the house during a party where you have 10, 15 persons, and then you know that that is not that the person had to run on the staircase to call someone close by to start the CPR. I mean, these are important issues that we have to analyze carefully. And I think you are right. Maybe in the future, really bystanders, cardiac arrest, CPR should be included, and very few where you cannot really be sure about the information regarding patient inclusion criteria.
Yeah, I would like to say we did some multivariate analysis with our data. And according to this analysis, the most important predictors of survival in our study was initial rhythm, definitely. Then it was time of resuscitation. And surprisingly for us, it was also age, but not the place of cardiac arrest. But of course, we have quite few patients. Yeah, so
thank you.
We need more data.
One of the questions that I had is for the arrest trial, the number of physicians performing ECPR was few. Jan, how many physicians were performing ECPR at your center during the trial? And for all the panelists then, how should this inform the next trial and clinically implementing this going forward?
I think in this way we are with the Demitris on the same wave, that we think there should be a limited number of people cannulating for ECPR, and I'm kind of skeptic to widespread utilization of ECPR on the ERs and cath labs everywhere. because this needs very highly skilled people and experienced operators. So in our center at the moment, we have 4 operators in the cath lab, which who have been trained, and we have established a ECPR on-call service, and those 4 people are online for ECPR service.
And I would say that the experienced intensive care unit staff is also critically important, because the rate of complications and multi-organ dysfunction syndrome in these patients is very high, and the treatment of these patients, I think, is the most challenging. It's the most challenging patient. The ECPR patient is the most challenging patient on ICU.
Yeah, exactly what Dan said is important. People discuss hours and hours about the cannulation, but this is just the first step. Of course, important and a prerequisite, but the most of the effort is the intensive care right after the nursing demands. We have sometimes 2-to-1 nurse to patient ratio, and those patients are very unstable after ECPR. They need a lot of interventions, they need a lot of volume, they are volume dependent, have a lot of complications, difficult to ventilate, and it's a very demanding for the staff and for the ICU. So you have to be sure, if you want to start ECPR program, about your capacity, about your nursing capacity, how many beds you want to fill up with ECPR cases. And so this is not about just a cannulation.
And on a kind of a related note, for those that do not survive despite ECMO, and there's a question by Mario Rugna, perhaps Jana wants to field this. What do you think from a donation option standpoint for those who don't survive despite ECMO?
Okay, yeah. Jana would like to answer that. You are muted.
Yeah, thank you. Yeah, we did a sub-analysis of the donors, and we had quite a lot of donors. Yeah, and it was in a standard arm about 3 donors, and in an invasive arm 90 donors who were accepted, and 2 donors with ROSC without ECPR. Yeah, so in this way, the organ donation is a quite very important thing which can help other patients. And in this way, I can mention the rhythm of this patient, because 40 patients of accepted donors had a PA, yeah, and 40% VF. So in this way, in spite of their poor survival, they can help other people.
So what do you think, actually, based on this analysis, and we also analyze our registry, which consisted of many hundreds of patients, is that probably we might have a different outcome, or primary outcome, or combined endpoint of saved lives. So if you combine those people you save and who survived the ECPR track, and then if you add to them the eventual survival provided by organ donorship, so you actually make a lot of good for the population. So in this kind of change of paradigm thinking, you may use this as a combined endpoint.
So Jan, let me ask you a question. I didn't see it, and I think we don't talk about it. Did you have a survival advantage in your trial of 6 months?
What do you mean, the survival advantage? 6 months?
Like, was ECPR, did ECPR improve survival?
Yeah.
Survival.
Yeah, exactly. Yes.
Well, I want to just point out that, we are trying to, I don't know, dialyze the, I forget what's the Greek saying. So we are trying to just be extremely picky about everything. Okay, so we have an intervention that improves survival at 6 months, improves survival at 3 months, improves survival at the hospital discharge, and we're saying, well, the neurological intact survival lost its significance. And I don't believe. What was your odds ratios, or not the odds ratios? The -1% plus 20. So we're focusing on the -1. But we ignore all the other because you picked 6 months to survive on neurological intact, right? So I like this idea about this is life and death situation. So my final question to all of you is like, if your mother, your sister, or your father required CPR for more than 20, 30 minutes, would you take your parents or your sisters or your siblings or yourselves to an ECMO center, or you wouldn't? The answer for myself is yes. As long as my kids are in school, I would want ECMO. So when people say about randomized trials, I cannot randomize anymore, right? There's no equipoise for me. So,
I think it speaks to one of the results that Jan presented back in the day when it was first out, was the Bayesian analysis that they had specified, which showed a significant benefit, but I don't think made it into the JAMA publication. Maybe that's something we'll see in a subsequent publication. I don't know if there's time for John to comment on that, or we can wait for another day.
No, I think if we can wrap up with just a little bit of closing discussion remarks, this has been wonderful. So thank you all. But yeah, if you want to comment and we'll go
no, I think it was clearly stated by Demitris that I think we have proven quite significantly that this intervention works. And of course, this is not an easy way to do. This is not an easy population. This is a multifactorial problem. Cardiac arrest is not a simple disease. And the cause of cardiac arrest and even cause of refractory cardiac arrest is difficult to solve and to treat. So therefore, we still need to be very sure whom we enroll into this ECPR track. And if we do it, then we have to be very sure that this chain of interventions works perfectly well. Otherwise, you don't have a chance for a favorable survival. And you have to practice. You have to train and practice EMS crews. You have to practice the dispatch center. You have to practice the communication with the crew on site to get the best information. You have to practice the readiness of the team on site, whether it's cath lab or whatever. So you need to practice cannulation. You need to train your team at the ICU. You need to debrief the team. You need also the post cardiac arrest care. You need a palliative team. You need a spiritual team. You need a outpatient ambulance. You need a nutritionist. You need a ethical consideration. So you need a bunch of things. You need a complex center to care for the patient. So this is not about an ECPR. This is not about a cannulation. This is about a very complex approach to this very disparate population. And if you do all this well, you can reach the survival of 30%, which is perfect.
Thank you, Jan. I think that's a perfect conclusion to this panel. I want to thank all the individuals, the PIs, and the participants in this discussion. This is a unique experience to have all these PIs in one setting for this discussion. Thank you all very much.
Thank you. Great.
Thanks,
Thank you.
everyone.
Bye.
We'll have this webinar posted on our website for anyone that missed us live. So thank you so much, and we appreciate everyone's time.
Good night.
Thank you.